Good morning, everyone. I'll be presenting a rare case of Prutscher's retinopathy. So, I'll be reporting a rare case of Prutscher's retinopathy, which showed rapid improvement with IV methylprednisolone alone. So, PR, first described by Australian ophthalmologist Ottmar Prutscher in the year 1910, it was encountered as a case of traumatic retinopathy following head trauma, which was associated with vision loss. Initially, he coined it as angiopathia retina rheumatica. This is classically a retinal manifestation of mechanical trauma elsewhere in the body and presents with acute vision loss. Incidence is about 0.24 per million per year, and it is bilateral in nearly 60%. However, since the retinal signs are transient, the diagnosis initially missed, the correct diagnosis can be only inferred retrospectively. So ours was a 28-year-old young man who came with a history of road traffic accident 3 days after he occurred the accident. He complained of sudden defective vision in both the eyes, but he had a history of defective vision in his left eye since childhood. On presentation, his best corrected visual acuity was 21-25 in the right eye, CF in the left eye. Rest of the anterior segment was normal except for a 4 mm pupil, but was reacting well to direct as well as concentric reflex. Fundus showed a hyperemic disc with peripapillary whitening, perivascular clearing along the vessels, along with cotton wool spots like pictures, which is actually Prutscher's fleckens, along with few preretinal hemorrhages. So this was a fundus picture in the right eye, and in the left eye you can see it was a large myelinated nerve fiber layer which has almost already involving the disc. So we did a FFA which revealed a peripapillary arterial blockage as well as areas of block fluorescence from the cotton wool spots and hemorrhages not involving the fovea. Late angiographic features released some mild leakage from small vessels near the areas of cotton wool spots not involving the fovea. Multifocal ERG was also done and revealed overall reduced wave amplitude in the right eye. Absence of findings in the left eye may be actually due to that protective effect from the thick myelinated nerve fiber layer. So we made a diagnosis of unilateral Prutscher's retinopathy, and we started him immediately on IV methylprednisolone 500 mg OD for 3 days, and consequently was continued on oral steroids 40 mg for almost 1 week. On follow-up, within 1 week, his best corrected visual acuity improved to 20/30 in right eye, CF in left eye. Right eye showing resolving Prutscher's flecken, no disc edema, hyperemia, or macular edema. OCT revealed minimal ellipsoid layer changes, but with not much intraretinal or subretinal fluids. And OCTA also showed a preserved foveal architecture. So the specific retina appearance of PR is due to occlusion of peripapillary terminal arterioles which supply the superficial peripapillary capillaries. Proposed mechanism is an endothelial damage leading to trauma, leading to activation of C5 component complement system which predisposes to aggregation of leukocytes which embolize and block the small arterioles causing infarct at the capillary bed. There are multiple traumatic as well as non-traumatic causes for PR, and it can present either binocularly or monocularly. So there is a diagnosis criteria which was put forward by Dr. Mugul. So this includes presence of Prutscher's flecken, presence of retinal hemorrhages, cotton wool spots, probable or plausible explanatory etiology, complementary investigation compatible with the diagnosis. A minimum 3 out of this 5 is required to fulfill the criteria. Prutscher's flecken pathognomic of PR but can be absent in nearly 50% of the cases, and there is a clear zone of nearly 50 microns on either side of the retinal vessels, and this is because of the presence of capillary free zone around the vessels and presence of high oxygen saturation. There is no specific treatment concord in the treatment, but many practitioners advocate observation alone, whereas some employ early corticosteroid treatment. Review of literature shows that there is a role for IVMB but with late response. However, few other studies claim that there is no specific benefit. But our case was unique because there was rapid visual recovery within 1 week. So to conclude, there is a paramount importance to raise awareness towards this different clinical presentation. Current studies are invaluable. Therefore, further research is mandated. Thank you.
Nice presentation, Rakhi. But when you're making your slides, just be aware that you need to have some kind of contrast. If you have like green slides with white on it, you can't really read it well. And red and green are colors that you would want to avoid,
Yes.
because of colorblind issues. So just keep that in mind when you prepare your slides. And I would think one case is just too early to, comment
Yes.
about the probable, yeah, but very interesting case.
So, Dr. Rakhi, nice presentation. In your last but one slide, you showed that Agarwal et al. That paper is having actually a series of cases. Otherwise, it is all case reports only published in literature. As you have rightly told, there is no concession whether to go for the steroid or observation only. In fact, we have a series of unpublished data where we did not find any big difference between these two. So you have to weigh the benefit of steroids, especially in road traffic accidents, keeping in mind the crash study, the
Yeah.
mortality was higher. So we have to take care, consider the other things, systemic things also while giving steroids. Otherwise, nice presentation. As madam has told, your these fancy works were actually covering the Prutscher fleckens which are present nicely in between the vessels. You can see nice diagnosis of Prutscher retinopathy. Thank you.